A 65-year-old man presented to the emergency department with complaints of worsening shortness of breath over the past week. He also noted swelling in his legs and mild chest discomfort. The patient had a history of hypertension and had been taking antihypertensive medication regularly. He denied any recent infections, fevers, or significant weight changes. He described the chest discomfort as a dull ache, not particularly associated with exertion, and it did not radiate. The shortness of breath occurred primarily when lying down or exerting himself. On physical examination, he had bilateral pitting edema in his lower extremities and jugular venous distension. His lungs were clear to auscultation and his heart sounds were normal. An initial electrocardiogram and chest X-ray were unremarkable. Based on his symptoms and normal cardiac workup, he was diagnosed with decompensated heart failure and was started on diuretics and advised to follow up with his cardiologist. The diagnostic error in this case arises from the premature conclusion that the patient's symptoms were solely due to decompensated heart failure without sufficient investigation of other potential causes. While the symptoms of shortness of breath, leg swelling, and jugular venous distension are suggestive of heart failure, other conditions can mimic this presentation. One important differential diagnosis that should have been considered is pulmonary embolism, especially given the patient's sudden onset of symptoms, chest discomfort, and risk factors like age and possible immobility due to leg swelling. Pulmonary embolism can present with symptoms similar to heart failure, including dyspnea, chest pain, and edema, and may not always present with the classic signs such as pleuritic chest pain or hemoptysis. Additionally, the clear lung auscultation and normal ECG do not rule out PE. Further diagnostic testing, such as a D-dimer test, Connecticut pulmonary angiography, or ventilation perfusion scan, would be crucial to rule out PE. Missing this diagnosis could lead to significant morbidity or mortality, as untreated PE can result in serious complications or sudden death. Pulmonary embolism can present with symptoms that persist for a week or longer. While PE often causes acute symptoms such as sudden onset of shortness of breath, chest pain, and sometimes hemoptysis, the clinical presentation can vary significantly depending on the size, number, and location of the emboli, as well as the patient's overall health and comorbid conditions. In some cases, especially with smaller or multiple small emboli, the symptoms can be more subtle and less severe, leading to a delayed diagnosis. The symptoms might be mistaken for other conditions like heart failure, respiratory infections, or even anxiety, particularly if they develop gradually or are intermittent. Additionally, chronic or subacute presentations are possible, where the symptoms evolve over days to weeks, often accompanied by vague symptoms such as mild chest discomfort, fatigue, or progressive shortness of breath. In the case provided, the patient's presentation of worsening shortness of breath over a week, along with mild chest discomfort and swelling in the legs, could be consistent with a subacute PE, where the symptoms have gradually developed due to partial or recurrent emboli. This underscores the importance of considering PE in the differential diagnosis, even in patients without classic acute symptoms, especially if there are risk factors present.